from greetings from Mumbai. This is one of the lecture in the summer edition of the teaching program. This morning I'll be talking to you on surgery of atrioventricular septal defects. So let's in the next few minutes see how we get along here. Oh, sorry, there's a hung up. All major congenital heart defects. Most of them have got Down syndrome, nearly 50%, and in Down's children, AVSD constitutes a host of cardiac defects, close to a quarter of them. And if you compare that with the general population, nearly it's 1,000-fold increase compared to the usual congenital heart defects in normal children. Let's see the pathology and embryology of these lesions. It's actually a spectrum of lesions, the etiology being abnormal development of endocardial cushions, and there's a defect in the atrial septum and AV valves, atrioventricular septum and AV valves, and many of them have got associated lesions. So on your left side, as you can see, is the normal heart, normal circulation, and the business area of the AV septal defects is what you see in these oval markings. Ventricular septum, the lower part of the atrial septum, and the two AV valves. So if you see the anatomy of AV septal defects, the atrioventricular septum is deficient. Both mitral and tricuspid valves at the same level, because normally it's the atrioventricular septum which elevates the mitral valve, which say the tricuspid. The ventricular inflow is shorter, more in complete AV canal than in partial AV canal, because there is more deviation of towards the apex of the AV valves. So this will lead to a left ventricular outflow which is longer, giving rise to the classic gooseneck deformity, with a normal inlet to outlet ratio which is equal. There is also a predisposition to left ventricular outflow tract obstruction, and the aorta is more anterior and unwedged. A few diagrams I will illustrate all these points. So this is what I'm talking about. So if you see the normal heart and you see the AV canal defects, you find there's an apical deviation because of the absence of the septum, and you have a shorter inflow and commensurately about a longer inflow, giving rise to what's called a gooseneck deformity in this region. Unfortunately, most of this is seen only by echo nowadays, angiograms, because we hardly do this for AV canals today. And also, if you see a normal cross-section of the heart, you find that the aorta is completely wedged between the AV valves. And if you see the AV canal, this wedging is much less because of the deviation of the apical deviation of the valves and absence of the atrioventricular septum. In addition, there's also inferior displacement of the AV node and the coronary sinus. The bundle of his is also displaced inferiorly, coursing along the inferior rim of the scooped out basal portion of the interventricular septum. So if you see that on the diagram, this is the normal area of the membranous septum and the bundle, and in AV canal, you can see it is more inferiorly deviated towards the inferior vena cava, and the posterior inferior part of the VSD is maintained, but it's pushed more inferiorly. Now, from the surgeon's point of view, this is what we see when the right atrium is open. This is the full AV canal. You've got the left superior bridging leaflet, inferior bridging leaflet, the left lateral and the right lateral leaflets, and that's the ventricular septum and the VSD which is there. So basically, we categorize AV canals into three varieties based on the extent of interventricular communications and separation into two distinct AV valves. We have partial AV canals, we have intermediate transitional AV canals, and complete AV canals. So if you see partial AV canals, we have a large ostium primum ASD. There's a cleft between the left superior and bridging leaflets. There is no VSD here, and two distinct AV valves, as you can see here, and you can see that there is a crux between the two AV valves separating them, and this forms about 5 to 10% of all primum ASDs. If you see the transitional AV canal, The constant factor is a large osteoprimum ASD, cleft between the superior and inferior leaflets that I showed you earlier. There is usually more tiny restrictive VSD. It could also be between some of the chordae which are attached to the crest of the interventricular septum, interventricular communication between the chordae, and two distinct AV valve orifices. In this, if you have a restrictive VSD, the common AV canal, this is called a transitional AV canal, or sorry, an intermediate AV canal. And if you have two distinct, you can further categorize the transitional AV canal. AV canal, more important, osteoprimum ASD, a large unrestricted VSD below the bridging leaflets, and one common AV valve orifice with left, right, and left components. So other features of AV canal which is significant to the surgeon, of course, cardiologist, because they'll have to illustrate these on the echo and also the other investigations. Size and extent of interventricular and intra-atrial communications, valve leaflet morphology, papillary muscle anatomy, valve regurgitation, and attachments of the chordae to the interventricular septum, relative balance of the complete AV canal over the ventricles, and other major associated cardiac or non-cardiac defects. Here are some more the most important thing in the AV canal defects is what is the left AV valve. Remember that in the AV canal defects, the left AV valve is inherently stenotic and it is abnormal. So it is wrong to think that it's going to function like a normal mitral valve. And the anterior mitral leaflet occupies more of the circumference, as you can see here, of the annulus than a normal mitral. The normal mitral valve, the AML is the dominant, the PML occupies more of the circumference than the AML, and it's exactly the reverse in the AV canal defects, the left AV valve, AVSD. The cleft is not a commissure, as support is lacking in the opposing leaflets, and annular dilatation predisposes to commissural regurgitation. So all these points have to be kept in mind when we are evaluating the AV valve because of its abnormality as compared to the normal mitral valve. Another important thing which has been done for AVSDs is the Rastelli classification. It was described by Gian Rastelli in '66 from the Mayo Clinic. And it's basically based on the extent of left superior leaflet bridging over the interventricular septum and its subvalvular caudal attachments. It does not take into account the inferior bridging leaflets, which displays greater anatomic variation. So just to summarize what Rastelli's classification is all about, then you have the superior leaflet, a lot of attachments to the crux of the interventricular septum, crest of the interventricular septum, and you have the type B, where you have some of these attachments coursing onto the contralateral ventricle, and type C, when there are no attachments of the superior bridging leaflet, and it's a free-floating leaflet, commonly seen in Down syndrome. So how useful is the Rastelli classification? Because we all keep talking about it. Well, not very useful from the surgical point of view, may have a limited role in the classical single patch technique, which is not done anymore. But recognition of the extent of undivided portion of the left superior leaflet over the interventricular septum is important, as the left superior leaflet needs to be divided in this technique. But in the current techniques of repair of AVSD, Rastelli classification is less important, excepting for the fact that maybe if it is very much type A, the long-term incidence of left ventricular outflow type obstructions may be a little more in these children. Pathophysiology. Large left to right shunt at the atrial and ventricular levels. There could be various grades of the left AV valve regurgitation. Extent of regurgitation augments the atrial and ventricular level shunts. There is an early onset of pulmonary hypertension, which could be earlier in children with Down syndrome. Management, well, surgical in all ages. Medical management is usually making them fit enough for surgery, particularly in the neonatal age, to carry them to an early infant age groups. And if there's any contraindications for surgery, and medical management basically diuretics, ACE inhibitors, digoxin, and control of the failure if it is till the child comes up for surgical repair. And diagnosis is by, I think all of you have heard from Dr. Kulkarni, who talked to Securities earlier, ECG, Dr. echocardiography, and diagnostic canals, because we can see the morphology of the left AV valve much better. It's important also to assess after the surgery in terms of either epicardial echo or transesophageal echo 2 or 3D, as the case may be, for the left AV valve, particularly after the correction. So what's the place of catheterization? Well, I think it's not the norm, and if you're doing the AV canals in early infancy, but certainly it has got some place in those older AVSD patients greater than 1 year to assess the pulmonary arterial pressures, vascular resistance, and the QPQS. But certainly, I think if the child is not doing well after surgery, post-operatively, there is a place for this to quantify residual shunts like VSDs and LVOT to decide whether we have to take the child back and rectify these problems. So indications for surgery and timing for surgery. The diagnosis of AVSD is an indication for surgery. Timing could vary depending on whether it is a partial AV canal transitional, which is basically low pulmonary blood flow lesions, non-PA pressures being normal. Maybe we can perhaps do it around 1 to 2 years of age, but certainly I think complete AV canals is one which is corrected very much early in infancy, at least between the age of 2 to 4 months of age. So if it's restricted pulmonary blood flow due to whatever reason, perhaps we could still wait around a year of age. What is the place of palliation, pulmonary artery banding in complete AVSDs? It's very rare in current practice because we are repairing them much earlier. But I think the place of banding may be in those cases of unbalanced AV canal associated lesions going to the single ventricle pathway in early infancy, or there is some gross medical contraindication to surgery, either with comorbid conditions or other major systemic anomalies, which with a patient, with a child who is stuck on a ventilator to get him off the ventilator. I think it's important before we take up the kids for surgery, what are the contraindications for surgery? At least I believe that resting saturations below 85% on room air, unresponsive to oxygen inhalation or exercise desaturation forms one of the contraindications. The other usual contraindications as seen in any gross left to right shunt lesion is small heart on X-ray with no pulmonary plethora and predominantly right to left shunt with no reversal with oxygen pulmonary vasodilators. I think all these forms, which is universally known as contraindications for surgery. The aim of the surgeon is to repair this lesion, that is to close the VSD, to close the primum ASD, and separate out these two valves and see to it that the left and right AV valves are pretty competent. So basically, there are three modes of repair which have been brought about. That was the single patch repair earlier, where we used to divide these leaflets, close the whole primum and the primum ASD and the VSD in one single patch. That gave way to a two-patch repair, recognizing the fact that these are never in the same plane. So we use one patch for the VSD and another patch for the ASD and separate the ventricles of the AV valves. And of late, there's been, when a VSD is not very much excavated, we use what's called a modified single patch because we use the directly with atrioventricular annulus and then close the primum ASD. So this here there is no patch to close the VSD, so only one patch to close the ASD. This is also called as the Australian technique of AV canal repair. So that is usually done when there is not much of scooping out of the interventricular septum. So the steps of the repair is to close the inlet VSD, close the primum ASD, and we usually do so with pericardium because it has been found that if you close with Gore-Tex or Dacron, any of the jets, MR jets which is there from left AV valve cause hemolysis. So usually the primum ASD is closed with pericardium, creation of two competent non-stenotic atrioventricular valves, closing the anterior mitral defect left, repairing the tricuspid valve, in the process avoiding damage to the atrioventricular node and bundle of hairs, and of course fixing any of the associated lesions like LHVC2LA, PD8, GD, or etc. So when we come to the basic surgical techniques, this is what the surgeon sees when you open. That is a primum ASD. This is a left component of the AV valve, the right component of the AV valve, the interventricular septum. and you can see here that's a VSD patch which is going to bridge this area. That's the VSD, and usually you find it's a boat-shaped patch when there is a not much of scooping of the interventricular septum. And once that is sutured in, we close the primum ASD after repairing the cleft of the after repairing the cleft of the left AV valve. And when we are repairing the cleft, we see to it that we don't take too much of the leaflet tissue, because that itself can cause it to disrupt and give rise to late AV valve regurgitation. Transitional AV canal, we use this is a small VSD which you really can't appreciate from the 3D image. It's not very much depth, so we close the cleft, directly hitch on this to the interventricular septum, and use a patch to close the primum ASD. This is how we close the cleft of the left AV valve. So either interrupted or continuous suture is done to close the cleft of the AV valve. This is the full anterior left AV valve leaflet. This is the posterior leaflet, which you can see is an opposite of normal. If required, we use some of annuloplasty or rarely a ring to reduce the amount of central AV valve regurgitation. And as you can see here, this is what we test that, and if there's any AV valve regurgitation, 2 small plicating sutures are also added if required. Now coming to the closing of the ASD, there are 2 varieties. In one of the varieties, to avoid a heart block, we close the ASD in such a way that the coronary sinus gets committed to the left side. Another technique is to see and stick to the annulus of the mitral or the left AV valve and circumvent the bundle area. So either way, as long as there is no heart block, is what it is. But if you direct the coronary sinus to the left side, there could be a small amount of desaturation, somewhere to the tune of 1 to 2%. An important technical point in AV canal defect surgery is how do we size the VSD patch. If it's a correct size, you find there is good apposition of the bridging leaflets, and there is no tilting or elevation of the annulus. But if it is too wide, you see, then the leaflets don't come about, and then you can have regurgitation of the left AV valve. And if the patch is too long, it sort of distorts the anatomy, and again, that can give rise to both right and left AV valve regurgitation. So sizing the VSD patch is one of the most important things in AV canal repairs. Just a few post-operative photographs. This is how, when we fill up the heart, when it's arrested with cardioplegia, this is how the cleft looks. This is the left inferior bridging leaflet. That's the left superior bridging leaflet. That's the site of apposition. And this is where, when we are, it's all in the process of the cleft which is closed, and this is the base of the closed of the primum ASD. And this is how this is the primum ASD. The left AV valve cleft has been closed, and the pericardium is used to close the primum ASD. A rare picture of what a double orifice left AV valve looks like. This you can see here, and both in this particular case, both had good subvalvular apparatus, non-regurgitant lesions, so we just left it all alone. But then this is one of the problems is they do develop left AV valve stenosis later on in life. Common associated anomalies seen with complete AV septal defects are LSVCs, sunroof coronary sinus syndrome, PDA, rarely coarctation, other secondary ASDs, muscular VSDs, tetralogy of Fallot, and any of the complex cyanotic lesions can be associated with this. A few things about Down syndrome and AVSD. 20 to 25% are AVSDs out of all cardiac defects seen in Down syndromes, and a quarter of the children have some cardiac defect. And as we know, with the Down syndrome, they can have hypotonia, CO2 retention, which leads to high pulmonary vascular resistances and pulmonary arterial pressures, so they can go into inoperability much earlier. Smaller airways contribute to this reduced number of pulmonary arterioles in the vasculature. And this translates into longer ICU stay and PH crisis in older children. And they do have type C Rastelli more common, and surprisingly, the surgical outcomes are much better in the Downs than in the non-Down syndrome, because the anatomy is more amenable to good repair. Well, unbalanced AV canals form a minority of the patients, and out of these, the right ventricular dominant unbalanced AV canals are more common, and left heart hypoplasia also is common. One of the important decisions the cardiologist and the surgeon have to make is the decision between biventricular and univentricular repair, and all these points need to be considered in this decision. And of course, more importantly, once we commit them to a biventricular repair, particularly if the left ventricle is borderline, is what's the growth potential and how this child behaves in the long term needs to be monitored. Important things of morbidity in surgery of AV septal defects is residual lesions, mitral regurgitation, tricuspid regurgitation, residual VSD, and of course the residual LVOTO or new development of LVOTO as the duration of follow-up increases. I think all of you will be encountering this, the postoperative behavior of AV septal defects. The monitoring lines which we usually put are arterial line, central venous line, left atrial line, and pulmonary arterial lines. That's what we practice. Not necessarily all the units will be doing this, but this is what we practice at our place. We frequently monitor right atrial pulmonary arterial saturations to determine any residual left to right shunt lesions. If it is greater than 10% or the absolute pulmonary arterial saturation greater than 80% on an FiO2 of 0.5, we consider that to be a significant left to right shunt, or if the QPQ is greater than 1.5, which will need prompt attention. And particularly if there is a concern of any residual defects, closure of the residual VSD has to be undertaken for better and recovery. If there is low cardiac output state, there is judicious use of inotropes, then keep on filling the child with volume, and that's where I think all these monitoring of the LA and PLIs are important. And the support we generally use are vasodilators because the left AV valve is the problem issue in these cases. Mildenone is preferred. And if there is pulmonary arterial hypertension postoperatively, in addition to the factors leading to pulmonary arterial crisis, I think what we need to know is also severity of the mitral regurgitation, whether there is any mitral stenosis, residual VSD, or there is LV dysfunction, which can contribute to the PH postoperatively. Outcomes of AV canals, I think in current era, it's about 1.5% mortality, and most of them, they have either a trivial to a mild MR, most of them, about 2/3 of them. A minority of them have moderate MR, depending on the spare and also the anatomy, which is important, and the fact that the child may be non-Downs because their tissues are not that very attractive for a good repair. But the interesting thing is there's no correlation between presence of MR preoperatively and its present postoperatively, because it has to come down if it is severe MR preoperatively after we repair. But then it all depends on also very much on the anatomy of the tissue and the morphology of the leaflet. There are a few older studies of long term, and if you see the probability of mortality, it is partial AV canal, of course, behaves more or less like ASDs, but complete AV canals, I think over the years, the mortality has truly come down. And if you see the percentage survival of, with the years after repair, certainly I think there is some degree of attrition, and most of this attrition either is due to the morphology of the left AV valve regurgitation, development of pulmonary vascular disease, and also the fact that because of the left AV valve, maybe ventricular dysfunctions. And if you see the long-term follow-up of complete AV canal and partial AV canal, obviously behaves more or less like an ASD lesion, and with little less, I would say, long-term survival compared to an ASD, because they are also left with left AV valve issues. But certainly, complete AV canal has got a much longer attrition in the long term compared to the partial AV canal. Here are the AV valve regurgitations, residual shunts if they are present, left ventricular outflow tract obstructions, particularly in the Downs kids and those with severe PH, later age of surgery, residual PH, and in the very, very small minority where they do develop a heart block is PPI and complete heart block. Risk factors, Risk factors: early era of surgery, older age of surgery, post-operative left AV valve regurgitation, preoperative left AV valve regurgitation, and double orifice mitral valve. With this very small, I think we can sort of disregard this, but certainly all these constitute the risk factors and increase in the hazard function as the follow-up in these children increases. Now, if you see the left AV valve behavior, it has certainly got a huge influence on the long-term survival. And if you see that left AV valve repair failure, if you it's very well competent, then that is the hazard function curve. Whereas if it is if a repair has failed, then obviously there is a lot of attrition. Now, just to show you a little bit of our experience in the current era, our experience of little more than 70 cases, of which 53 have been complete AV canals, partial AV canals, and you can see here, complete AV canals have been mostly in the early infancy. We've lost 2 cases due to sepsis and very severe left AV valve regurgitation. Most of them have, even after repair, they do have a trivial to mild left AV valve regurgitation, but then we monitor this with LA pressures and PA pressures. They are usually normal. And a minority of them have had moderate AV valve regurgitation. Most of these had been in downs. 4 had severe, 3 we had to refix, 1 we had to replace the valve, and that is one of the child whom we had to take back expired in the post-operative period. So issues in the surgical correction of AV canals is 1, when to correct, and I think there's no doubt about that. Complete AV canals are corrected very much in early infancy, ideally between 2 to 4 months currently. Technique of corrections, I think 2-patch repair is one which is most commonly utilized, and Australian technique in indicated cases. Debate about cleft repair, yes or no. Certainly it is yes. I think there's enough data in the literature available that if you don't close the cleft, the regurgitation of the left AV valve is higher as the child grows into an adult. And how do we close it? Check left repair. I think that's still controversial. You can use horizontal mattress sutures, interpret sutures, continuous sutures. I think that is the jury is still open. How much mitral valve regurgitation to accept? Either overcorrect or stenosis? Well, I think it depends on we always try to see that there's no regurgitation, but I think a trivial regurgitation should be all right. But if it is overcorrected, you don't have to have gradients of more than 2 to 4 of mean gradients in the mitral valve. Anything more than that, I think we'll have to have a relook at the repair. Coronary sinus directed to left atrium or right atrium, I think it depends on the surgeon's preference, because the most important thing here is to avoid complete heart block. And if any technique which avoids that is the best technique. What are the monitoring lines we require? As I told you earlier, we are pretty aggressive in putting monitoring lines. So we put both LA and PA lines. But of course, there are units which dispense with one of these lines and still get good results. So in conclusion, AVSD has varying degrees of AV valve abnormalities, interatrial, interventricular communications. Complete AV canal is best repaired around 2 to 4 months of age, and the repair is earlier if there is congestive heart failure or moderate to severe left AV valve regurgitation. Unbalanced AV canal present a management dilemma, biventricular repair versus univentricular repair, and there have been efforts now to move towards biventricular repair. But then we have to weigh that with the long-term issues of LV growth, etc. Currently, AVSDs can be repaired with very low mortality and morbidity, as I've told you earlier. And finally, the left AV valve is the one, and the left ventricular outflow tract obstruction. They are the 2 important lesions which determine the long-term outcomes. Thank you very much. Yes, I think if we find that there's a left AV valve regurgitation is severe, and you find that the child is not gaining weight, we try to wait as much as possible for AV valve replacement, because it's got other issues, and then very small kids, we have only got a prosthetic valve which is available. So I think if we have a moderate to severe AV valve regurgitation, we try to give them as much time as possible with medical line of treatment, see how they thrive well, how they gain weight and all that. And at some point of time, if you find that the child is still incapacitated, that's when I think we have to seriously consider thinking of AV valve replacement. Having said that, it's been my experience that for the amount of regurgitations we have, the indications for AV valve replacement, it's very, very small. So this has to be sort of a last resort thing after all the other medical measures have failed. And sometimes we may even have to go and re-repair the valve, particularly the clefts and all that which they have given way, and give a chance of conservative repair treatment than rushing into an AV valve replacement. Outcomes of single patch versus Australian technique with regard to CPB times and well, I think the single patch repair now is not done. I mean, in the sense that either two patches or an Australian technique with regard to cardiopulmonary bypass times and AV valve regurgitation. You know, I think in the important in the current practice with the CP and myocardial preservation techniques available, CPB times and cross-clamp times have taken a sort of a back seat. I think more importantly is we have to fix the valves and it's much more accurately than earlier. You don't have to rush a repair just because you have to reduce your cross-clamp times. Yes, having said that, I don't think we have to unduly have long cross-clamp times, but I think earlier we used to give a lot of credence to this, that you have to do a quick repair, keep your cross-clamp time short. It's not like that anymore. Our whole emphasis is on to give a good AV valve repair with good competence. So, so in Australian technique, I think it's important that we have a good AV valve, because if you don't choose your case well, what happens is if you close the VSD directly by a single, it can distract the left AV valve and give rise to increased regurgitation. So I think that's why whenever you have a case where there's a lot of scooping out of the interventricular septum, you would not like to do the Australian technique. You would like to do the formal two-patch technique.